Assalamu alaikum wa rahmatullah. Let's start this second talk on sarcoidosis this afternoon. A lot to cover in then 10 minutes, but we'll try to see what we could go through. The stuff is hopefully very clear to you. Most of the stuff that you know of from your medical education till now. Multi-organ chronic condition which is mainly to do with the presence of non-caseating granulomas in those organs. There are certain cases where you could just diagnose this clinically and then treat accordingly. In fact, they don't necessarily need the treatment. For example, the typical Lofgren bookish syndrome or Hereford syndrome, lupus burden. So even if you need to treat, you don't need to diagnose them based on any other investigation. Rather, clinical diagnosis should be okay. It's a benign condition, and more than 50% do not require any treatment because they have significant reversibility. Now, the epidemiology, as we know, affects mainly the young and the middle-aged women of African-American origin or Scandinavian origin. It's much less common in our part of the world, Asian and Hispanic origin. Very rare in peds, but still seen in 30% of the patients would be in elderly population. There's no clear data due to the variation and also self-limiting nature of the disease about specifically how much and what is the incidence. But this is what the data you could find online. 20 cases, maybe in America, it's a little bit more, 1 to 2 male to female ratio, African about 34 in 100,000 population. It's much worse with extrapulmonary involvement and females with regards to prognosis compared to male and pulmonary involvement, because it is picked up early and then you can treat them hopefully before they end up being completely fibrocavitary disease stage 4. The two peaks between in 20s and in 40s and 60s. The tumor necrosis factor and the receptor are the mainstay where they tend to affect this and inside this pathway. That is why infliximab has been showing quite promising results in order to treat these conditions should they require it. Other markers tend to be just of some monitoring purpose, a useful tool in selected group of patients, but not necessarily as a diagnostic tool. Almost everyone would present with some sort of, we're talking about respiratory cases now only, so with dry cough or some dyspnea or chest discomfort, and a lot of them would have some involvement of the lung, even if you cannot identify anything on the lung function test or on the scan with the stage 1. And that is why the idea of diagnosing them with the tissue biopsy in parenchymal involvement or in lymph node involvement, should you want to exclude other possibilities. Hypercalcemia is not that common, but hypercalciuria is much more common, and I think very much ignored by us unless we deal with renal sarcoid, where you find all the stones, and they're normally present with the stones, renal stones, and problems related to kidneys. So I think we should just take this as a message, though. A third of the patients will have hypercalciuria, to be checking their urine samples as well for calcium, which I hope be simpler and easily available test. These are all non-specific tests and certain biomarkers. I mean, if you wanted to do for a specific differential diagnosis exclusion, for example, borreliosis, leprosy, liver disease, lymphomas, then it is important to exclude those. ACE inhibitor would affect your ACE level, as we know, and likewise the polymorphism with regards to deletion and the insertion of the genes there. This relatively new soluble interleukin-2 receptor, it's released by these cells, so it is good to have that, but it's not recommended as yet, but something for future, hopefully, especially in the extrapulmonary disease, where it has prognostic value as well. It's much more sensitive than ACE and even lysozymes. with significant sensitivity and specificity of ATs. Lung function, it does not correlate at all with the parenchymal involvement. So you may have completely normal lung function test, and they may have quite bad marker there, and then the scan shows some fibrosis, and likewise vice versa, because it depends on whether they have got some airway involvement or not, and hence the obstructive picture in about a fifth of these patients. The most important lung function abnormality would be reduced DLCO. Chest radiograph is the other way around. 5 to 50% of patients would have bilateral hilar adenopathy. Again, on its own, it doesn't need any further intervention other than monitoring to follow them up in the next 3 to 6 months' time with a repeat chest X-ray, seeing the improvement if the normal pain and arthralgias have been treated with NSAIDs. If they have radiological involvement, then one needs to be a little bit more careful about monitoring these. Even in that case, 3/4 of the patient with a stage 1 disease would have resolution. 2/3 would, stage 2 would have some resolution as well. Other than the stage 4, there could be resolution at any stage. So that is why there's no clear guideline as to when to observe and when to scan them. So perhaps clinical judgment is the most important thing to take into consideration. Guy's staging is well known, and this is what we deal with. High resolution CT scan would be the way to look for the parenchymal involvement. Obviously, you can get some lymphadenopathy, but the true way of identifying pure lymphadenopathy is contrast enhanced. But these days, plain, simple, non-contrast CT scan, even high resolution CT scan can show you good level of certainty whether they have got significant adenopathy or not. The typical micronodular appearance scattered throughout the fissure and the vessels is important in the lymphatic distribution, and sometimes they just coalesce together to make a conglomerate mass, and at times surrounded by the nodular appearance. And we see that on the radiology of these patients. So for example, this patient with a central nodular opacity with surrounding nodules, smaller nodule around that is called galaxy sign, one of the telltale sign. More likely than not, this would be a pathognomonic of sarcoid. Another one, periphyseal beading. So whenever we look for high resolution CTs, a periphyseal beading, the craggy appearance of that fissure, we try to find that out at any slice, and then that gives you a little bit more certainty that this could be sarcoid. And you have, enlarged adenopathy, as you could see, and calcification. So obviously here, TB would be a good contestant there. Treated tuberculosis can have calcification as well as the sarcoidosis. Sometimes you have miliary mottling, again, a differential for your miliary TB. So obviously you see more of miliary TB than sarcoid. So just be aware that remains a possibility. And finally, this is a stage 4 and fibrocavitary disease, which is a bit of a nightmare because it has got tendency to cavitate in such a way that you start having hemoptysis, major hemoptysis, and also having mycetoma there, the fungus ball. Some other features you could see: ground glass opacities. Sometimes there is honeycombing, linear scarring. PET scan has taken some press really with regards to identifying extrapulmonary more than the lungs, bony involvement, for example. Fiber optic bronchoscopy or normal bronchoscopy is quite a decent tool for this condition. If you find this nodular cobblestone appearance, then that is quite significant feature, and you would just take a tissue from there, a few snippets from there under the microscopes showing the granuloma. And we tend to get T-spot or IGRA of any sort to exclude TB, because then you are in a dilemma: is TB or is this sarcoid? And then just treat it, and then they get significantly better very quickly. So a 30% yield, even if there's no abnormality endobronchially. So hence, during bronchoscopy, we, if you're suspecting sarcoid, we tend to take secondary carina or subcarinous biopsy. We just take few from each of those, and very low risk of any problem really with that. So 4 or 5 chunks from secondary carinas, and then you get, if you just prove that there is a granuloma, then it's good. Now, transbronchial biopsy really is very good, but the trouble is, where would you biopsy? It's very, very difficult. And if you did it, because it's quite scattered, and if you identify that specific segment and you've done it, the risk of pneumothoraces tend to be a bit high, and people have over the time lost their ability to do transbronchial properly. So it's important to not forget EBUS in this situation, because you could exclude quite a few other conditions. If you look at the EBUS TBNA, you almost 100% sure that you could get a decent sample, even with the normal, only very mild lymphadenopathy. Really, you can get a good result. So EBUS really is a gold standard these days that we use, not worldwide, obviously, and then BAL sample. So that's another thing to take into consideration. BAL mainly to exclude the infection and malignancy, TB, for example, but also to see this CD4 to CD8 ratio. If it's significantly positive, more than 3.5 and more than 10, it's almost certain that this is going to be a lymphocyte predominant and a sarcoid, and a very good response to treatment, even with the parenchymal involvement. Obviously, you exclude all of those differentials. Cardiopulmonary exercise testing is good as to identify the subclinical hypoxemia, but also for the cardiac, because it's quite common to get cardiac involvement, and you do not find much in sarcoid other than the some hypoxia or some palpitation. So cardiac, MR scan would be the next stage, but we don't normally, we refer to cardiologists for that, really. Asymptomatic patients, you don't need to treat, as you know, you just observe them. Arthralgia, some NSAIDs would do the trick. Steroids remain the mainstay of treatment, and there's growing trend that you do not start off with 1 milligram or 0.5 milligram per kilogram body weight, but rather, especially for sarcoid, it's a half the dose or less than that, about 40, even 20 milligrams. And over the course of next 6 months, you would see significant improvement. And in acute exacerbations, even for 2 to 3 weeks worth of steroids has done the trick in a lot of patients. So there is more trend toward going low and tapering off quicker. If someone could not be maintained on, say, 5 to 7 milligrams, 7.5 milligrams, or maximum under 10 milligrams per day of steroids, then a second-line agent as a steroid-sparing agent, it would be quite useful. Like in the HP talk, we heard that there's not much data to improve to suggest that mycophenolate is better than azathioprine or steroids or as a combination, but we do not use those as the main immunosuppression, rather as a steroid sparing agent. So you can come down to the lowest possible dose of steroids, say 5 milligrams, and have some mycophenolate or methotrexate in this case. If there was steroid resistance, then you have to go for immunosuppression. You can taper if you can't taper off quite low, likewise the side effects and the patient desire. So this is what the normal guideline these is. The 2021 guidelines from ERS is that steroids, obviously, and over the next 6 months, if you do methotrexate, I mean, it has taken a lot of favor nowadays, methotrexate, especially in sarcoid. Now, people have this reluctance, methotrexate is known to cause interstitial lung disease, pneumonitis, inflammation, but there's no data to support that. There has been a lot of trials on that, and you can very safely start methotrexate in these patients. Obviously, you would keep an eye on them and monitor them for potential complication of methotrexate, but this is by no means a contraindication. And finally, this infliximab thing. Infliximab is anti-TNF alpha, very highly recommended these days if patients fail on those two and do not maintain them. There's a lot of data out there for that. So in summary, if you just look at this low risk to high risk and intermediate risk, and you consider all those three different modalities to treat these patients, and finally, if they do not do good, then Dr. Imran Niazi is there to help us if possible for lung transplant. Nizami, sorry, Nizami. Prognosis for stage 3 and 4 is quite high. And then the monitoring. So we keep monitoring those patients until we get them a bit better. And that's where we stop.